Good evening. I am Alice Mong, Executive Director of Asia Society Hong Kong Center, and it is my great pleasure to welcome our audience to tonight's episode 7 of the Coronavirus Update, Hong Kong and Beyond. And as this is our 7th episode, and when we started in February 14th, primarily our audience has been generally Hong Kong, but in this last few weeks, we are really, unfortunately, as it become a global pandemic, COVID-19, our audience has expanded. So we're really delighted that today we have Professor Marc Lipsitch from Harvard T.H. Chan School of Public Health to be with us today to talk to us, answer some questions about what is happening in the U.S. And we're really delighted that it's his morning in Boston, and I'm talking to you here from Hong Kong. And since last week when we spoke, a lot has happened here in Hong Kong and globally. Hong Kong's case has doubled. I think many of the returnees, people who have come back to Hong Kong, our cases went from just around 200 to now over 400. And the death is still at four number. Tokyo has postponed its Olympic to 2021. And we also heard Prince Charles, along with Harvard president and his wife, tested positive for COVID-19. U.S. Senate also passed a U.S. $2 trillion Corona rescue package, and Spain's death toll is climbing, is now the second highest next to Italy. And China, good news on the China side, and the Hubei side, they're thinking about lifting the travel ban and also lockdown of Wuhan. And so today we're, again, delighted to welcome Professor Lipsitch to be with us. And he is Professor of Epidemiology at the Harvard T.H. Chan School of Public Health. Good morning, Professor Lipsitch. Can you give us an update, since you're based in the U.S., about what is happening in the United States right now in terms of COVID-19? I know cases, unfortunately, New York has seemed to become the epicenter. So if you can give us an update of what's happening.
Yeah, thank you. And it's a pleasure to be there. I've had a long friendship with the group at Hong Kong University, Gabriel Leung's group, since SARS days, and have been working with them a little bit on this. And so it's nice to see Hong Kong at a distance. So in the United States, we have now every state and territory of the United States has cases. Testing remains very low in most places and quite uneven. As you mentioned, New York State and New York City are one epicenter, but I think the first one to emerge was Washington State and the Seattle area. It has not grown quite as dramatically, it seems, as the New York epidemic for reasons that are not totally clear. New Orleans, Louisiana is another place that's now showing a very, very rapidly growing and significant epidemic. And we don't fully know the extent because the United States has been really trailing the rest of the industrialized world in testing for a variety of reasons. So the situation in the U.S. is that many of the coastal cities are under stay-at-home orders of various levels. Schools are closed in many places. There is a lot of regional variation in the level of concern and control. Part of it politically associated, meaning that groups that have more trust in our current national government have less concern about this because of the messages coming from Washington. I think the debate in the United States has already begun to discuss the question of how soon can we stop these control measures, which I think is extremely premature. Of course, everyone's very concerned about the economy and about the impact on vulnerable people, as they should be. But I think we're at an earlier stage in the U.S. than a lot of places, and people are already getting impatient with the control measures.
As you mentioned, I think the national level, how realistic is President Trump's wish that by April 12th, Easter, that U.S. will shake off the virus? Is that wishful thinking, or?
It's magical thinking. I mean, there's no epidemiologist in the world who thinks that's a plausible scenario.
Let's talk about some of the things that you've written. I think you gave an interview in SCMP last month, and that said it's dangerous to assume that COVID-19 is another type of flu. And do you think that this was a prevailing view held by most people in the U.S. and globally, that it was just another flu-like, pandemic flu? And I think people weren't proactively managing this crisis or being concerned about it. So do you think that was the case?
I think it was at the time, and it still is in some quarters. I mean, we're still hearing both from our president in the last few days, and it's hard to take very large doses of listening to him, so I haven't heard all of what he said, but both from our president and from some other people in the press, that we don't stop society for seasonal flu, and people are going to die from this, but so far it hasn't been that many, and so this view still exists and is still powerful. The problem with that view is that the expected number of people who get infected with this is considerably more than seasonal flu, because it's a pandemic, and that's what happens in pandemics, flu and otherwise. And also the risk of dying if you get infected, by all current data, is much higher, maybe a factor of 10 higher than seasonal flu. There could be errors in that, and maybe it isn't, but I think what makes me say that it's not comparable to seasonal flu is that seasonal flu does not overwhelm the intensive care systems of multiple countries, and this has, and that tells you something about the product of how infectious it is and how lethal it is.
Well, in your op-ed in Washington Post, you had said the real number, because of the testing, is actually could be 10 times higher than what is reported. And do you still think that's true? I mean, because the undertesting in the United States?
Yeah, I mean, the United States has done less testing than almost any other per capita, than almost any other industrialized country. The public sector numbers, at least, are about 30-fold lower than South Korea per capita. There may be there's some debate about whether there's enough private sector testing to make that number not totally representative. But the CDC's website, if you divide that number tested by the population and do the same thing for Korea, you get a factor of 30 difference. So we really are not, and even Korea probably was missing some of their milder cases. So we know that there are a lot of cases that don't come to medical attention because they're so mild, and I would say there's also quite a number of deaths that have been missed because they weren't suspected. For a long time we only tested people if they had a link to Wuhan or then to China. So we're behind the curve.
So you have written about social distancing, and right now it's a word that all of a sudden that we are all very familiar with, as I think 3 billion, a lot of the people around the world are experiencing it. 3 months ago, we probably never heard of this social distancing. But in some ways it has been effective, and in certain cases, for example, in China, where it is definitely a lot more stringent, we know it's effective in that right now we're seeing it coming out of this COVID-19, this lockdown in some ways. But some of the countries in the West are still kind of debating with it. And here in Hong Kong, we ourselves are also seeing that, because for a while there, we kind of let our eyes off the ball. So can you talk about how do you feel how has social distancing been effective, and how has kind of your view on the social distancing, and how should it be kind of practiced in the US, or what is your advice on that?
Yeah, I mean, the reason why social distancing is an important control option is that it's essentially the class of interventions that work whether or not you can tell who's infected, because the whole purpose of social distancing is to keep people apart physically, whether or not you know anything about their status. And of course, you especially try to keep people who are sick apart from others. So that's why it's kind of our last approach after the sort of case-based approaches where you follow individual cases and their contacts after those things have failed. So in the United States, or are not possible because you just don't see enough of the cases. So in the United States, we're sort of stuck with social distancing and similar interventions as our main options for the moment, because testing is so limited that we can't track down the majority of cases. I actually think as the weather changes and everything that causes COVID-like symptoms except COVID goes away, testing is paradoxically going to be less important in the United States, because symptomatic diagnosis will be more and more accurate, whereas it wasn't in flu season. But so Hong Kong is at a different phase where those cases were found and tracked and contacts traced and quarantine and isolation used in combination with relatively comparatively mild social distancing, as I understand it. And the issue with is that the other piece of it is that social distancing can kind of supplement those approaches where you're still tracking cases, but you're also trying to stamp out through social distancing chains of transmission that you don't see. So I think as imports and or locally transmitted cases become more of a problem in locations that have had it under control relatively well, like Hong Kong, more social distancing along with continuation of those measures is going to be the really only available option. But the goal of social distancing is to get the case numbers down to where you can count them and trace them.
One of the questions I was particularly interested is this research conducted by the Imperial College experts, showing that in this unmitigated epidemic, they're predicting approximately over 510,000 deaths in Britain and 2.2 million in the United States. It sounds really dire, and it's a very concerning scenario. And would you agree with this estimate, or is it too extreme? And some of the best case scenario and the worst case scenario, if you can share in your expert opinion?
Yeah, I think those numbers are consistent with what we know about how the epidemic works if it's unmitigated. There's a lot of uncertainty, and I'm sure Neil Ferguson and his colleagues would be the first to agree with that. But the uncertainty is kind of almost academic, because if it's a quarter of that, it's still catastrophic and 10 times worse than seasonal flu, approximately. If it's 500,000 deaths, that would be about 10 times worse than seasonal flu in the United States, or more. If it's twice that, of course, it's even worse. So I think I'm not as focused on the exact numbers, because I think there are some big uncertainties, but the magnitude of the problem is on a scale unlike anything that we've dealt with in recent years. And I think that's the main message. And, we all have our scientific debates about the ups and downs, but I don't think there's any real disagreement that the death toll and the toll on our healthcare system would be immense.
I'm curious, in terms of what is the Harvard T.H. Chan School of Public Health been doing to kind of help your work to help stem the tide of this epidemic? And particularly, I also want to ask you about this in reading the release in the Harvard website about the collaboration with Chinese researchers, particularly the Guangzhou Institute of Respiratory Health and Dr. Zhongnan Shan. So can you tell us more about that work that you're involved with?
Sure. So the Harvard Chan School and our Center for Communicable Disease Dynamics has been working on this with a team of around 24 people since mid-January, the end of January. We've been doing communication to try to get scientifically valid information out about the potential magnitude of the threat, about seasonality, about other sort of basic issues of how infections spread in populations, about the role of social distancing, and other topics. We've produced around, I think, 8 or 10 scientific papers that are in various phases of peer review, including one in collaboration with Gabriel Leung's group in Hong Kong. Those papers have been on topics like undercounting of travelers to sort of understand the imperfections in detection of cases, which I must say I would not have realized at the time might be now applying to China, which is now the recipient of the travelers rather than the source. So we've done a lot of work on that. We've done a lot of work on modeling social distancing and its consequences, and a number of other things. The exciting collaboration with the Guangzhou Institute is something that arose quite early on because of an industrial sponsor gift from Evergrande, and the idea there is really to just accelerate work along multiple lines. There's epidemiology is one, diagnostics, therapeutics, and vaccines are among the major goals there. And my understanding is that, excuse me, we've just had well, it's not my understanding, it is fact that we have had an internal process to start allocating those funds. And the details of how to collaborate best with colleagues in Guangzhou are still being worked out, as I understand it. But it's really an exciting opportunity to both expand what we're doing on many fronts, technological fronts and epidemiological fronts, but also to collaborate with people who were on the front lines. Now we're more on the front lines, and share experiences. So we're very excited about it.
Well, I think this leads me to the question, I think in one of the interview you had with Science Magazine, in kind of referring how this time scientists are now collaborating in a way that's very different for this outbreak from previously. And can you kind of, it also kind of breaking some of the old traditions or old molds, and also in terms of speed. So I wonder if you can talk about some of that type of collaboration, how different now than compared to maybe like 17 years ago when you said you had worked with Professor Leung. And by the way, we're going to have Professor Leung, Gabriel Leung, with us next Friday to continue episode 9 of this conversation. So, but how has collaboration in some ways, and also technology, changed from, compared to SARS 17 years ago? And also China as well.
Yeah, well, I think in many ways, I think one way is that just the network of high quality scientists has coalesced in a way. We all know each other now. Not all of us, obviously, but many of the leading groups know each other well and have experience collaborating. So as an example, when Joe Wu and Gabriel Leung and others in their group, Ben Cowling, were working on a project that they knew was very complicated and wanted to make sure that they were doing it correctly, they asked if we could recode the whole thing to just make sure that we were getting the same results they did. So essentially, it meant that we helped them figure out how to write their methods in such a way that they were reproducible by us without looking at their code, which is a scientific value. And it also meant that work that we were doing for other reasons on the traveler data turned out to be an important input into that project. So it meant that just because we were all friends and had worked together and knew what each other could do, it was just very efficient as a collaboration of an actual collaboration of sort of writing a paper together with them as the leaders. What I think is more remarkable even is just the speed at which everybody is sharing preprints. Both, and the journals have, for the first time, in my opinion, really made that easy. They've really said public health is more important than journal embargoes and all the paraphernalia of scientific publishing, and have really encouraged us to work together by sharing results as soon as they're available, and think about publishing as the second thing. That's had its ups and downs in that there's been, because the preprint now has become the currency of scientific communication, there is no filter on preprints, and the filter by legitimate scientific groups is pride in getting the answer right, and the scientific attitude that I would rather find the flaws myself before someone else does, which is characteristic of the best scientists, because we all make mistakes. We just want to find them before we share them. Not every group has that ethic, and so there's been some spectacular nonsense put out in scientific preprint literature, but much of it has also been very quickly corrected because Twitter is playing a huge role in scientific communication right now, and in sharing ideas about what's new and what's new and wrong. So
I hear Slack is also a tool you guys have been using as well, right? So right now, we're going to turn to some of the questions from our audience. Some of them, now that our audience has become global, as I said before, I think initially when we were having this conversation, it was very much a Hong Kong audience in February, but now with the global pandemic, some of these questions are coming from all over the world. One of the questions from the audience is, which drug, if any, are you most optimistic on for the cure? And when will we know about cure? And if cure is found, how does the impact how does that impact spread and mortality rate?
I'll start by saying that I have been trying to learn as much as I can during the 18 hours or so that I'm awake every day. And one thing I have done is walled off drug trials from that, just because I don't have the time to learn everything. So I have not followed that. I've been focused more on the epidemiology. Broadly speaking, what I can say about drugs is of course, there's a lot of hope for a number of them, and I think the dose of realism that we need to remember is that many antiviral drugs, for example, the influenza drugs, work well at the very beginning of an infection and are less effective, or there's less evidence that they're effective, at least if a person has gotten very sick and been sick for a while. That doesn't mean this will be true of all these other drugs, but I think we should have tempered expectations, because stopping the virus is the first step, but then the immune response itself can be damaging, and these drugs may not do that. So I think, of course, we have to try everything, and maybe there will be a prophylactic drug that can be taken or otherwise, but I think we will just have to see.
One of the question is, can you talk about, this is something my colleague just shared with me. You had recently wrote about the human challenge study. Can you, I think, talk about a bit about that for our audience?
Sure. So it's not known by everybody, but there are something like 30 different examples in the world right now of infections that scientists give to consenting volunteers in order to study something about that infection, whether a treatment or a vaccine or something else. So this is a thing that happens. It's a way of generating scientific knowledge. And one of a proposal that we've made in a preprint that we released a couple of days ago with colleagues Nir Eyal and Peter Smith is that human challenge studies, voluntary human challenge studies, could be used as a way of speeding the approval of vaccines. The idea is that the longest step in the vaccine approval process is the so-called the phase 3 trial, the trial that tests whether the vaccine is protective against infection. And the reason that it takes a long time is that you have to immunize a bunch of people, compare them to placebo recipients who don't get the vaccine, and see who gets infected, and that takes time. With a human challenge trial, the idea would be to take much smaller numbers of people who are at the lowest risk of complications, immunize some of them, give some of them a placebo, and then and then compare those who get the vaccine when they are given a deliberate challenge with the virus. So that obviously raises a lot of ethical concerns. That's not something you would do lightly. But as I say, this is something that has been done for other infections, and in some ways, the ethic and what our paper describes as reasons why it could be made relatively low risk, especially the net risk for people who are otherwise also going to be exposed to the virus in their natural life. And also, it has an ethical advantage in that one concern about every vaccine, but especially coronavirus vaccines, is the possibility of what's known as enhancement, where the vaccine creates an immune response that's harmful to the control of the infection. That's been seen in other coronavirus studies. So it's a real concern, and the ability to rule that out in a small number of people before you give the vaccine to many people is a real advantage, in my view, compared to doing it in larger numbers of people. So we think it's an important thing to discuss, where we understand that there's a long conversation to be had. But if we could cut some months off the process of getting an effective vaccine, that would be a very large contribution.
Correct. This is another question from our online audience. What do you think, will the spread of COVID-19 last into 2021 and beyond? And what could be done to mitigate the impact globally?
Yeah, I think the most likely answer is yes, especially if our control measures are effective, because what ultimately controls and stops a virus from spreading, excuse me, is immunity in the population. And the better we control it, the less we build up immunity in the population. So if our control measures are successful, then the duration becomes longer. I think a number of people have proposed, and I think this is the most likely scenario, that this becomes the fifth seasonal coronavirus. If it does so, because there will be a lot of immunity in the population, it won't be, it would be, we would certainly expect it to be much less of a public health threat once immunity has been built up in the population through previous exposure. But I think we have a preprint suggesting that scenario. Others, Anthony Fauci has mentioned the same thing recently. I think that's, if not the most likely scenario, a very likely scenario, that it just becomes a seasonal coronavirus.
One other question from the audience also is, why do you think the spread in Italy was so rapid and widespread?
I think that it was rapid because it was not until the problem got really large that social distancing and other control measures were undertaken. And we saw from Wuhan, for example, from an analysis that our group did, but just from looking at the data, in Wuhan, the city was put under near lockdown on January 23rd, and the demand for critical care continued to grow until almost February 23rd, around February 23rd. So one of the problems is there's a big lag between when you impose control measures and when the burden on the healthcare system starts to reflect those control measures, because it takes a long time for people infected on one day to become sick enough to need intensive care. So I think one of the lessons of Italy is unfortunately that if you wait until you know you have a big problem, then you continue to have a bigger problem for several weeks after that.
Are you I'm just curious. It seems to be the first wave of this virus was very much Asia, in China and this part of the world. And then the second wave seems to be the developed countries and so on and so forth. Are you seeing this third wave going to be the developing? I mean, we're hearing cases now of India, and also a lot of the cases of people returning to India and brings the cases back. So is that going to be the trend, or is it going to be more weather related, do you think?
It's a good question. I mean, I think part of the detection, or part of the difference between the developed and the developing world, is detection. Indonesia, for example, claimed to have no cases for a long time and then suddenly had a lot. And I think, and to be fair, so did the United States, but not for quite as long. And we have more of a public health ability to pick up cases. But I think part of it has been sampling effort and sort of background levels of severe disease that sometimes hide blips of a new disease. I think one open question is whether countries that have a younger population on the whole, which is typical in the developing world, may have a little bit less of a toll, because clearly old age is a risk factor for bad outcomes. Although we don't excuse me, we don't know whether that's the age effect is really age, or whether it's due to exposure to environmental toxins or smoking or other things. So that remains to be determined. But I think we have to really be concerned about the large fraction of the world that hasn't noticed that it has a large problem yet. I don't think there's much evidence that weather can control this virus by itself. And Singapore, Hong Kong are pretty warm places in my memory, and MERS spread around the Middle East, which is a hot. So I think weather is not going to be the solution. It may provide some benefit to control that warmer places have a little bit less spread.
One question here is asking about the herd immunity theory. What is the minimum needed to go back to normal is the question. And is cure, herd immunity, vaccine testing, all are nice, but what is the minimum or is it a combination to get back to the normal, if there is a normal?
Yeah. So herd immunity is just what I was describing before, of the buildup of people who have been exposed and therefore hopefully can't get infected, or at least would be very mild and not very contagious if they did get infected, which seems to be the pattern with the seasonal coronavirus. You don't have lifelong immunity, but if you get a second infection, it's much milder and you don't shed much virus. So the buildup of immunity is what we need to get back to normal. The two ways to do that are through natural exposure or through vaccine or some combination. And the proportion that have to be immune is really dependent on the contagiousness of the virus, the so-called R0, or basic reproductive number. A lot of estimates, including a lot of estimates, place that number around 2 or a little more than 2 or a little less than 2. If it's 2, then 50% of the population needs to be immune before spread can be controlled. If it's 3 or more, then if it's 3, then 2/3 of the population need to be immune. And there's been a lot of discussion among scientists in the last few days that the doubling rate of the virus in Italy and other parts of the West seems to be faster than it was in Wuhan and in other parts of China. And the doubling rate gives you some information about the contagiousness. So I think there's a consensus building around the number 2-ish. And now I think that consensus is being challenged by new data. So I think it's going to be in the range of 1/2 to 2/3, but stay tuned because there is new data coming in.
Your colleague at Harvard, Michael Farman, said that SARS-CoV-2 is a close cousin to SARS, and that it uses the same human receptor, ACE2. Finding the right antibody may be the key. And where do you think we end up in terms of antivirals, vaccines, and other therapies? How quickly do you think the suite of treatments, if and when available, would work to counteract the virus spread?
I think that's Michael Farzan, who's used to be a colleague but has moved to a different institution. But he is a real expert on this topic. As I said before, I think the development of therapeutics, we need to race to do it, but the trials will take, once we identify a promising compound, the trials will take a couple of months, and identifying more promising compounds is also underway. So I don't really have a prediction about when that will happen because it depends on which compounds actually work. But that's one of the goals of the Harvard Guangzhou collaboration, for example, is to try to identify promising molecules.
This is also from the online audience. What would be leading indicators deciding when to relax social distancing measures?
that is an important question that we've all been discussing a lot here, especially because our president is suggesting we should just do it without indicators. I think if we could show that the prevalence of infection in the population was going down steadily and was at a low enough level so that a resurgence of the virus would be controllable before it overwhelmed our hospital and intensive care capacity, that's when it would be. So in our modeling work on social distancing, what we suggest is that you would have a threshold to take it off, and then another threshold of prevalence in the population to put it back on, because we won't have developed enough immunity in one wave to really control the spread. So we will expect a resurgence if we take it off. You have to get it down far enough so that you can tolerate some coming back before you put it on again. So this is not a good cycle to be stuck in. Nobody thinks this is a good solution. But from the perspective of controlling the virus, until we have a vaccine or some other solution, this is what we have available.
And this is another question. Are we seeing different strains of the virus in US, Europe, India? And what are the chances of its mutations?
That's another important question that comes up a lot. RNA viruses, like coronaviruses, mutate all the time. The reason why we can tell the source of a virus is because we can track which mutations occur. And most of those mutations have no important biological effect. They just, we can read them off the sequence of the RNA, but they don't change the biology. So the probability of mutation is 100%. It's happening as we speak. The harder question is the probability, or whether there are strains that are different in their biological properties. There have been some spectacular reports about the L strain and the S strain, which were quickly debunked by skilled virologists. That's an example of one of those preprints that probably shouldn't have left the lab it came from, but got a lot of play. So far, there's no evidence that I'm aware of that there's any biologically different important variation in the virus. But there clearly is mutation, and it clearly needs to be watched. So I think people have a tendency, I've observed, to always look to the virus as the source of every new strange observation. And sometimes that's right. Sometimes the virus does change. Not this one so far, importantly, but viruses do change. But people's mental order should be, first, I bet there's something new about the way that we're seeing the data that is different from how we were seeing the data before. And then the next best guess is usually that the people involved are different. And the third best guess, in my opinion, usually is that the virus has changed. So we need to keep that in mind and not jump to the conclusion that it's a change in the virus.
This is another question from the audience. Some of them are technical, so I'm going to try to do my best to ask this question. What do you think about the recent findings by Didier Raoult on the efficacy of
hydroxychloroquine?
Yes, as a possible therapeutic? What are other good alternatives?
That's another drug question, and I'm just going to, again, not really answer it because, as I said, I have decided that other people are better qualified than I am to pay attention to that, and I'm going to focus on other stuff.
Okay. And this is another one I think is also kind of technical. How do you think about the opportunity for pooled PCR to accelerate testing coverage?
That's an interesting idea, and it's been discussed a lot. The idea is that if we have limited test capability, we could combine the swabs from multiple people, or the swabs from multiple sites in one individual if we're doing that, and and just see whether all of them together test positive. There are some limits to doing that in terms of technical limits, but that approach works well if most swabs that you take are negative, because then knowing that the pool is positive gives you more information. Whereas if most swabs are positive, then all the pools are going to be positive almost. So it depends on what kind of population you're screening, and also the purpose. So for surveillance, for understanding what is the rate of infection in the population, that's a very promising strategy, I think. For clinical care, of course, you don't want to know how many people, you want to know which people. You want to know if this person is infected or that person. And then the pooling is less efficient by far, because then if you find a positive, you have to then figure out which one is positive. So it depends on the purpose.
Here, you also have written about a study on children being affected by COVID-19. And in fact, as I recall, our first episode 1, when we spoke to Ben Cowling, and that was an area that he particularly was interested in looking into, how COVID-19 is affecting children and how. So can you talk about how your research or your feeling about the children being affected by COVID-19, if the situation persists, how long can we go without children in school? I mean, right now, all the school closing, it's going around in almost every country. So talking about the role of children in this COVID-19.
Yeah, well, I hope Ben does those studies. He may be doing them as we speak, because he would be the person I would look to answer that question. Along with other colleagues, but he's really well positioned. It remains a mystery. I think the current understanding is that children do get infected, they do produce virus, and so they are, at least in principle, capable of infecting others. And then people focus on one of two things about children that give you opposite views of whether they're important in transmission or unimportant. On one hand, they don't get very sick, and they often don't cough and sneeze as much, it seems. So that would mean that their ability to spread the virus is less. And actually, work from Ben and colleagues in Hong Kong was one of the first to show the importance for flu of transmitting of symptoms in transmission, that you're more likely to spread things if you of course cough and sneeze. So that's one hand. The other hand is, if you don't know you're sick, then you're less likely to isolate yourself or have people stay away from you. And so maybe children are more likely to be contagious than someone who's visibly sputtering and coughing. So I think we're just not really there yet in terms of knowing, but studies in households and studies in schools, if they're open, will be the ways to figure that out.
This is an interesting question in terms of almost a wishful thinking. In your capacity, if you had $100 billion US, how would you use it today to cope with COVID-19? Is that enough to kind of tackle this global pandemic?
I don't know how to even begin to answer that. So let me imagine that I had lots and lots of resources, because I don't process 10 to the 11th dollars very well. Don't really know even how to think about that. But to me, I mean, apart from mitigating the economic costs, which is going to cost, we're trying to spend $2 trillion in the U.S. For that, mostly for mitigation of the economic costs. So putting that aside, I would work very hard to build capacity for intensive care and hospital capacity, because that, of course, makes us more resilient and also makes us able to do the sort of on and off social distancing more efficiently. I would put a lot into, I mean, there's already 24 or more vaccine efforts underway. I would put a little bit of effort, it wouldn't be very much money, but it would be some where I would put effort to develop a real menu of options for how to speed that process up. And I know people are doing that. And also to consider all the options for testing, including human challenge studies, including trying to figure out whether convalescent serum is protective, where you take the antibodies from one person and give them to another, and other sort of non-orthodox types of approaches, and then I think this is also in progress, but I would start screening libraries of compounds as much as possible to find ones that we haven't thought of. So those would be some of my technological solutions. In the US, we're really hamstrung by a lack of personal protective equipment. So in the short term, that's a real problem, but doesn't seem to be a good solution to how to manufacture a lot of it very quickly.
I think I'm running out of question here, so I think most of the question you've answered. But I guess one of the question I have for you in some ways is, if not Easter, as the president had said, what do you see in terms of kind of a timeline when we will get out of this globally, this global pandemic? Kind of give us an idea of your personal, what you're seeing right now, where you're sitting.
Yeah, it's really hard to give a good answer to that because it depends. In the short term, it depends on how successful our control is. And the more successful it is, the longer it will take, which is an awful trade-off. And then in the longer term, it depends on whether we find some kind of technological solution, a vaccine or a really good drug or combination of drugs that make this something we can afford to let spread more. And so I think those are the two unknowns, but they're both unknown. So it's really hard to give a number. But I think it's clearly months and into next year, unless there's some really unexpected positive development.
And you're from where you're. So I guess I'm looking at optimistically. We don't have I guess I'm looking for answers. We're also nervous about here in Hong Kong, especially with the resurgence. Because for a while there, we kind of took the eyes off the ball and thought we were out of the woods. And are you seeing that also in China as well? Because with this lifting of the travel ban and so on and so forth, and China seems to be ready for it to get back to work. But do you also see a possible resurgence of the virus? And some of them also, some of the stuff that I've been reading, there are some of them do get the virus back, even though they've had it. So is that something you were concerned about?
You mean individual people get the virus back?
Yes. How concerned? 10%, is that what I read?
I haven't seen that. I would want to certainly, if you have
I'm reading the newspaper, and I think it sometimes says 10% of the people or whatever. Maybe it's just, you haven't read that.
I think I would have heard about that, okay. but maybe not. So please share that information.
If you haven't heard of it, I think I'm really, that really calms me. But I think that's really my questions, and I really want to thank your taking time from your busy schedule to share with us. I think you've answered a lot of everybody's concern. It's just, I think we're still, I think in Hong Kong, we're a little further ahead, and maybe 2 months, and we've had a little bit of a slip, but I think considering it's still only 400 cases, and but it's one of the lessons for me has been, I still kind of stay vigilant in that, the social distancing is still something that we still have to practice regardless of until this global pandemic is under wrap, and doesn't seem like it's going to be in the next couple of weeks.
It's not going to be soon.
All right.
Yeah, I mean, I think it is unquestionable that Hong Kong, Singapore, China, and Taiwan, all, and some other places, South Korea to some extent because of MERS, but the first list because of the experience with SARS, really learned how to take this kind of thing seriously and responded quickly, and there were some missteps certainly, but that's why you guys are in a better position right now than we are. Is we got lucky in SARS and had no real spread in the United States, and that left us vulnerable. So you paid some price in the past, and I think you're benefiting from that now.
We're still, yes, I think, thank you for that closing thought. And we, on that note, I would like to share with the audience, Asia Society on our global website has some wonderful resources, and including past webcasts, episode 1 to 6, as well as future webcasts. In fact, on Friday, March 27th, 8:30 a.m. New York time, Eastern time, we're going to be having a webcast on lessons learned, flattening the curve in Korea by my colleagues, Tom Nagorski. So please join us tomorrow morning for those of you in New York. People have time, so please tune in. And we also look forward to bringing you episode 8 and 9 next week of coronavirus update. We will have Professor Gabriel Leung with us, and we are looking forward to talking to him about what's happening in Hong Kong, and also kind of the future in terms of his advice on social distancing and what Hong Kong can do better to get us out of our current dilemma. So on that note, I want to thank all of you and remind all of you that we're all in this together, and together we will come through this. And but in the meantime, stay tuned at asiasociety.org for more information about these live webcasts. And again, thank you, Professor. I'm wishing you good health. And if you're ever in Hong Kong, we look forward to welcoming you in person into Hong Kong. So thank you so much for joining us. All right.
Bye-bye.
Good night.